So, good afternoon, and we are going to start a very interesting session that's 2 minutes to win. In just 2 minutes, you will learn a lot of tips. I'll इसका नए वाला दो। So, I'll request the panelists to be here. Dr. Parul, Dr. Harbans Lal,
Peel, lift and after sculpt technique.
Dr. J.S. Tityal,
This is a novel technique for break.
Dr. Prashant Bavankule, Dr. Kudlu, Dr. Kirti Singh. You can come here. It will be better. Dr. Parul. Every time you have to win only. Dr. Parul, Dr. Jagat Ram and Dr. M.R. Dogra. I'm expecting them soon. I think a lot of programs are overlapping. एक मिनट इधर आ जाइएगा. Okay. कर्सर कौन सा है? अच्छा ऊपर. नहीं बस ये वहाँ खोलना. हाँ. नहीं जो वीडियो है पीपीटी है दोनों हैं इसके अंदर. ऐसे कंबाइन है. 2 मिनट्स खोलना ऊपर वाला सबसे ऊपर इसमें पीपीटी खोलनी है बस इसके अंदर वीडियो इंसर्ट है ये कंटिन्यूस चलता है ओके हाँ एंड वॉल्यूम दे देगा जरा वॉल्यूम So, what we are going to do here is, we'll show a video. I would like to request the presenter to be here also. We'll show a video up to 2 minutes. That Dr. Bavankule, please. That will be followed by some questions from panelists and even from all the delegates also, except who are contesting or who are in this completion. They can't ask question. Rest of the people can ask. So, Dr. Mohan is for you. So, yes. So, first is Dr. Nilesh Kumar. Please come here. So, sir, he's your completer. Capsular origin to prevent Rexis runoff. There's no voice?
Yes, there is video, voice was, sorry.
I'll do it. Voice इधर से बंद करो नहीं probably it's from there they've connected. No? Voice सबको देखना जरा सा okay. There should be voice in this. Voice, you can raise it. Yeah.
So this is a capsular staining. We did it the blue, and then we are creating a soft cell. The idea of this is to break all the fluid pockets, because That is the unpredictability. When it goes on the fluid pocket, then you get suddenly you get a runoff or you get a Argentinian flag sign. So what you do is gently massage, and this won't happen if you are using HPMC. It has to be a visco cohesive agent. So you break all these pockets gently. It doesn't harm. I have done around more than 250 cases now, and it never breaks the capsule. So with this, with single piece, you will single go, you will get a 5.5 to 6 mm rexus. It never has failed me. I have not got a Argentinian flag sign, but few here and there rexus runoff I have got. You can see at the end of the case, it's completely central and well stabilized, round and perfect capsular rexus. So we'll see one more case. You can see here, in that there were spokes. In this, there is a sure shot rexus runoff if we are not taking care, because there are unpredictable fluid pockets here and there. Same thing again, just sweep it here and there. You can just see how the fluid pockets are breaking, and they're started communicating with each other. Wherever it is not happening, just poke it with your visco cannula tip. Again, the rexus marker comes on. So this is Haldipurkar forceps, excellent. So you can go through main wound and you don't have to worry about that the AC gets collapsed. You don't need to refill the visco elastic with using Haldipurkar's forceps. So with that again, you are going to get a round perfect rexus. Thank you so much for this opportunity, sir.
So what do you think, how it is going to help by pressing it only?
So all the fluid is coming in the center. So when we do a central puncture, that's the time where we have maximum amount of visco, and that's the maximum amount of positive pressure that we are maintaining in AC. So at that time when it comes out, the fluid ooze, it won't let to have a rexus runoff or an Argentinian flag sign.
Your soft shell technique is the reverse. So you push the methyl cellulose.
No, ma'am, I put a visco dispersive and viscoat over it, and then a visco cohesive bolus below that. So normal soft shell technique.
So basically you're relaxing anterior capsule, just
Yes.
taking flow from that
Fluid from
reducing the pressure on that side.
Yes.
So it works well.
Yes.
I think the key center, because when you make the nick in the rexus, if
Yes,
you're intumescent, wherever the main thing is your infraventricular pressure, if it is just corresponding to the beginning of your rexus, that's where it's pressure.
Yes, ma'am.
Please take home message is that please make it just uniform so
Yeah.
that there is no one pressure at one point and the nick doesn't go.
Yes.
So gentle
So
massage
that is
your
the
take
idea.
home that make it uniform,
Yeah.
infraventricular pressure, so that the rexus
Yes.
doesn't run off in one direction.
Thank you.
Thank you. Dr. Shalini Kumari. She is going to present lateral tarsal strip procedure for ectropion.
Lateral tarsal strip procedure is done in the case of tarsal ectropion. After giving local anesthesia, first lateral catatomy is being performed. And then orbital ring is being exposed. Next, inferior canthalisis is being done. Observable sensation can be felt at this point of time. Next, the lateral side is being cauterized just below the tarsals with a monopolar cautery. 50 number blade is used to give an incision at the gray line. Next, anterior lamella has been separated from the posterior lamella, and that strip of anterior lamella has been excised. Next, just below the tarsus where it was cauterized, it is being cut to fasten out the strip. Conjunctiva is being stripped off with the help of the 15 number blade, and intermarginal strip is being excised out to prepare a denuded tarsal strip, which will be attached to just behind the orbital rim so as to correct it. 40 proline sutures will be used for the same. Attachment will be at the proposed site in the periosteum. Sutures are being tied up. Next, new lateral canthal angle is being created with the help of the 80 vicryl sutures. Next, orbicularis oculi muscles will be closed with the help of the 60 vicryl, and skin will be closed with the 6-proline. Thank you.
Just tell about the procedure.
It's a very simple procedure. I think apart from oculoplastic surgeon, everybody can learn it. We can use it in cases of ectropy and entropy, and basically we change the vector, and also if there is any lateral canthal tendon laxity, since we are fastening a tarsal plate, so the length can be excised and we can do it correctly. Instant correction on the OT table you can see, and it's a fantastic procedure, everybody can learn.
So you would need laxity of the lower lid for this?
No, ma'am. As such also, if there is not laxity, we can change the direction. In this case, it was a inferior retractor release, basically. Whole thing was everted. So if I am just changing the vector, it actually creates a pull just behind the orbital rim at the level of the Wittner's tubercle, and so it got instantly corrected instead of going for any other procedure.
Do you have the tear film status pre and post?
No, ma'am, I didn't check it.
And you didn't show any picture pre and post you have?
I do have. But it was a 2-minute video, so I thought
Okay.
not to include it as a whole.
Thank you very much. I think it's a wonderful procedure. And we come now, the next topic is visco expression of the nucleus in manual 6 by Dr. Ranjit Singh Dhaliwal. Dr. Dhaliwal, sir.
Here visco expression of the nucleus in manual SICS. In this video we are dealing with a rock-hard black cataract and a ready-to-construct pupil. Both these conditions are a nightmare for any cataract surgeon, particularly phaco surgeons other than the masters.
We'll restart it.
Here visco expression of the nucleus in manual SICS. In this video we are dealing with a rock-hard black cataract and a ready-to-construct pupil. Both these conditions are a nightmare for any cataract surgeon, particularly phaco surgeons other than the masters. Such cataracts are always accompanied by lax zonule. The corneoscleral tunnel is made with a crescent blade and a side port is made with a 15-degree knife. Closed chamber, circular curvilinear capsular axis is performed and keeping in mind the size of the nucleus, the radial nicks are given all around the rhexis margin. The anterior chamber is entered with a 2.8 mm keratome. The nucleus tumbling technique in real time. A gentle hydrodissection is performed with 26-gauge cannula. The nucleus is tapped on the opposite side to release the trapped fluid, and the cannula flips the nucleus out into the anterior chamber, partially. At this stage we shift to visco cannula. Visco does not let the anterior chamber collapse and has a cushioning effect on the PC as the nucleus is prolapsed out of the bag. Nucleus is delivered by visco expression. This reduces the repeated entry of instruments into the chamber and does not allow the anterior chamber to collapse at any step. Thanks for watching. Regards from my infirmary, Nabha.
Sir, you would like to say anything about your procedure? All explained.
It's all
Just curious to know why you did a rhexis first and then made the cannon.
We shall be presenting here visco expression of the nucleus in manual SICS. In this video we are dealing with a rock-hard black cataract and a ready-to-construct pupil. Both these conditions are a nightmare for any cataract surgeon, particularly phaco surgeons other than the masters. Such cataracts are always accompanied by lax zonule. The corneoscleral tunnel is made with a crescent blade and a side port is made with a 15-degree knife. Closed chamber, circular curvilinear capsular axis is performed and keeping in mind the size of the nucleus, the radial nicks are given all around the rhexis margin.
all cataracts and never had a drop because it supports it. No. This is the nucleus. You place it here.
Nice technique, Dr. Aliwal, but only one question is, I think probably such big nucleus, you may require a tunnel of around 8.5 to 9
Yes, sir.
mm.
We had a big tunnel,
Yeah.
but we've never sutured these tunnels.
Yeah.
We've never sutured these tunnels.
No, you need not
Not
have to
required.
suture, provided if you
Not
put in the
required.
superior temporal, I think astigmatism goes to less.
Yes, sir.
Thank you so much. Now we move on to next presentation. Dr. Kumar, doctor, you will be presenting here. Please present, but it will not be counted in the competition. So no scoring for this presentation. The third hand, modified irrigation tip for bimanual IA.
In flax, the rex's size or the height of the resection can be adjusted. We normally keep it at 600 microns, so it's 400 microns above and 200 microns below the anterior capsule. Post-flax, to perform bimanual IA in a well-dilated pupil, one can easily hold the cortical matter just below the margin of the anterior capsule and aspirate the cortex. Let's look at a case of flax in a very hard cataract. During phacoemulsification, the pupil constricts below the margin of the CCC. So now the problem begins. Here we are using the irrigating cannula to hold the constricted iris away, but due to poor grip, it keeps slipping and makes it difficult to do cortical aspiration. Look at the struggle, and the iris keeps slipping. So we invented the irrigating Y. To the irrigating handle, we attached an attachment like a Y, and this attachment actually helps to hold the iris away. With the aspirating port, we can go beneath the margin of the CCC, hold the edge of the cortex, and aspirate it. The design of the irrigating Y is in such a fashion that the PC is kept away because of the flow. The procedure continues. Again, the iris is held with the Y portion of the irrigating handle, and the cortex is easily aspirated. With change of hands, the procedure is repeated, iris is gently retracted, the anterior capsule margin is visualized, and the cortex is aspirated. In conclusion, the irrigating Y is a very useful instrument for an atraumatic retraction of the iris and aspiration of the cortical matter by avoiding the use of iris hooks in a non-dilating pupil or an intra-op miosis. Alternative uses are feeding the aspirating port, residual cortical aspiration after IOL implantation, facilitates hydroimplantation of IOL to guide the leading haptic into the bag, help to lift the IOL, support it and clear the viscoelastic from behind the IOL, maintaining toric alignment by pressure on the IOL during viscoelastic removal.
So it's 2 in 1.
Thank you, sir.
Any comment?
No, we just, this was an incident where we were having a myotic pupil after a flax case. So retracting the iris, it was a floppy iris, but then retracting became difficult. It came to the size of the rexis itself. So then we had to use a Y and then keep injecting viscoelastic. So we thought of this as an instrument which can maintain the chamber as well.
Yeah, nice actual innovation. I think we should take really tip from you that sometimes with a very bad iris, I think this really helps. Yeah.
It's available otherwise commercially? Or?
Yes, it's available with
Yeah,
Epsilon.
if Kumar would have been come, means definitely it would have been one of the topmost runner for the champion. Mohan is really feeling very happy that his contender is not there here. Yeah.
Dr. Mohan, sir? Yeah.
Don't start till I tell. First of all, let me compliment Vinod for this wonderful innovation of 2 minute. The main idea of the 2 minute session is that you have to make it very simple and which can be practical and not very complicated, sophisticated stuff. And that's what I'm trying to do here. And can you start my video? You can see here in this particular case, yeah. This is the magic of the cotton bud. And this cotton bud, yesterday I demonstrated in the live surgery as well. When you come out of the eye, you can see the PCR enlarges. Okay? If you pull out of the eye, you can see here, this is a toric lens. I use only coaxial irrigation aspiration. When you pull out of the eye, you see what's happening. The toric lens shifts the axis. Okay? Again, this is a patient who's got iris IFIS. You can see the iris is coming out. and the pupil becomes smaller and smaller. Again, another patient, you can see after the irrigation aspiration, the iris is coming out. So to avoid this, what you do is just take this cotton bud, which is available, everybody. It's not even one paisa, okay? You just put it there and see this, just hold that when you come out. Hold that cotton bud. See this? No shalling of the chamber, nothing. Don't you deserve a big round of applause for this? Yes. See this again, toric lens. See this? And coming out, it doesn't move a micron. And see my Callisto image, exactly the same. Thank you very much, ladies and gentlemen.
Dr. Mohan, but I think you need not have to seal also. That is what you wanted to tell. End of the surgery, just put the bud there.
Put the bud, but don't leave the bud there forever.
I think it's cost less than $1.
Absolutely.
Not 1 paisa.
1 paisa, sir. 1 paisa. It's a very simple tip. Just do it. Yesterday I demonstrated in the live surgery. The anterior chamber does not, you need to, otherwise you need to have, Namrata was telling yesterday, you have to inject, you can inject viscoelastic. Problem is injecting viscoelastic, every time you use inject viscoelastic, and you have to depend on an assistant to inject viscoelastic. Otherwise you have to hydrate the ports. That also you need to be very good in a left hand. Doesn't matter at all. Just take a cotton bud, you try it tomorrow. Tomorrow is Sunday, make it Penday.
So we move on to the next topic by Dr. Shivani Patnaik, the story of trailing haptic, tips and tricks to guide the haptic into capsular bag. I think it's a quite common problem with all of us.
Trailing haptic in its journey to follow the leading haptic, which almost always enters the capsular bag easily. Let's see a few routinely used IOLs we have: the single piece, the 3-piece design, Rayner design, and the closed haptic Lucidus design. To perfectly guide the trailing haptic into the bag, we need proper instrumentation. A Sinskey hook slips at the optic haptic junction multiple times because of lack of proper grip and support. Oops. Whereas a T-hook perfectly engages the optic haptic junction and dials the IOL into the bag. Notice that the optic and the leading haptic are already in the bag under the CCC margin. There is a 2-directional force required, one downward and the other rotational movement to guide the single piece IOL into the bag. This is a 3-piece IOL being inserted directly through a widened main incision with a McPherson forceps. We may use a secondary instrument to stabilize the optic at this point. A T-hook is now used to engage the optic haptic junction and then dial the IOL downwards and rotate it into the bag. This is a closed haptic design IOL. Note that an iris repositor is used as a side instrument to guide the unfolding trailing haptic into the bag while the injector is still releasing it into the AC. In an alternative approach, after injecting this IOL into the bag, an iris repositor in the non-dominant hand is used to guide the trailing haptic by sliding the IOL downward and to the opposite side simultaneously to place the entire trailing haptic in the bag. This is a 3-piece IOL being injected into the bag. Note that the optic and the leading haptic are already in the bag. The T-hook now engages at the optic haptic junction and guides the IOL downward, and the IOL is finally rotated into the bag. Here the IOL is injected under irrigation and the aspiration cannula is used to direct the optic haptic junction downward and into the bag. This technique reduces the need for visco removal after IOL injection. Thank you. There are some times when the trailing haptic remains in the sulcus if the technique of inserting it into the bag is not correct, if we just push it down. So correct forces to be used to rotate the trailing haptic into the bag.
So with this T-dialer you can have 2 directional force,
yes.
Downwards and sidewards
and rotational,
also.
yes.
That makes the life much easier, I think. It's okay, it's very clear.
Thank you.
Thank you.
Thank you.
So we move on to the next talk, that's buccal mucosal graft in case of weak EH by Dr. Vishakha. Dr. Vishakha Sandevar. Sir, come this. Okay.
8-year-old male child came to the OPD with complaints of recurrent episodes of photophobia, redness, itching, watering, blurring of vision and blepharospasm in both eyes since few years. On examination, patient had bilateral refractory papillae and shield ulcers in both eyes. Patient was on long-term topical steroids and topical immunomodulators for almost more than 6 months. Patient also received supratarsal injection of triamcinolone in upper tarsal papillae. Still, symptoms were not relieved. What to do next? We planned buccal mucosal grafting in this child. Under general anesthesia with nasal intubation, we marked the area slightly larger than conjunctival raw bed on lower lip mucosa. Marked area dissected using 15 number blade. The bleeding vessels cauterized. The edges of the raw lip mucosa were approximated using 5-0 Vicryl suture. Then the harvested graft thinned out by excising submucosal fat and fibrovascular tissue. Oral mucosa is known to be slightly non-responsive to allergic stimuli. Hence, we decided to take oral mucosal graft. Then 4-0 silk suture passed through upper lid. Subconjunctival incision was taken without damaging tarsal plate, 1 to 2 mm from the edge of the papillae. Tarsal conjunctiva along with giant papillae was excised with 15 number blade. Mucosal membrane graft was sutured to conjunctival edge with 8-0 Vicryl. Rest area is covered by amniotic membrane graft and sutured with 8-0 Vicryl. BCL applied to the eye and eye closed. Post-operative medications, topical antibiotics, topical steroids in tapering dose and topical lubricants were added. In early and late post-operative period, no recurrence of giant papillae or shield ulcers was observed in any eye. Here we can see the post-operative picture of the patient with smiling face. Thank you.
Yeah, it is a nice technique actually, but it is done by your senior, Dr. Suchi, I think. Yeah.
Consultant.
Okay.
So in later phase there is some irritation, persisted long itching irritation, persisted
No
for
sir.
long.
Patient is 1 year post-op now and no recurrence is there.
So what is the mechanism that works, because you've used both buccal mucosa and amniotic graft. So what is doing what?
Traditionally we use buccal amniotic graft or mucosal membrane graft. We here tried buccal mucosal graft additionally because it is slightly non-responsive to allergies. So
It's not responsive to allergy. So you
Yeah.
see that it's better immunoprotective.
Yeah.
You're doing that, and because the area is larger, so then you also have
Ha,
to put the
had to
amniotic
cover
graft.
with
So
amniotic
a smaller
membrane graft.
portion of buccal mucosa,
Yeah.
and then a larger
Amniotic
and
membrane
then you
graft.
kept him on immunomodulator
For
one
6
eye or
months.
both the eyes.
Both eyes.
And they do well
Yeah.
in extreme cases.
Yes. Yes.
Thank you.
Thank you.
So we move on to the next talk by Dr. Chetali Sharma. She is going to speak on eye detective. How a small routine eye examination can help us to detect a rare entity. Dr. Chetali. Problem in this? Okay.
The mystery of a 12-year-old girl who presented to us with a chief complaint of diminution of vision in right eye. There was no history of ocular trauma or surgery. The parents were also concerned that sometimes the right eye looks abnormal in a certain case. On examination in right eye, the vision was 612 parts N6, improving to 66 parts N6 with refractive error of +1 dioptric sphere, and the left eye unaided vision was 66 N6. But here, not where it ends. In primary gaze, there was bilateral mild ptosis, and on extraocular movement, we found in the right eye, in adduction, there was widening of palpebral fissure, and on abduction, narrowing of palpebral fissure with globe retraction with all the other extraocular movements normal except this little glitch. Marcus Ganjow winking phenomena was negative, and we came down to the diagnosis of congenital cranial disinnervation disorder, probably inverse Duane's retraction syndrome. Do you know that there are only 4 reported cases of inverse Duane's retraction syndrome of congenital etiology till now? So it's not always about giving those glasses and sending the patient off. Sometimes routinely doing simple eye examination like extraocular movements can also tell us about big revelations. Thank you.
Message is very clear.
The video is nicely nicely made. So you're trying to say that the reason for amblyopia, the vision not improving beyond 612, is the microtropia?
Yes.
So is there, it would, just to complete for your next time presentation, have that orthoptic chart also. So in terms of what was the prism diopter, was there a primary square, was there like a foria compensated, like a 9 case, and a charting.
Sure.
That will just complete the whole thing.
Okay.
Did you do patching therapy or anything for her?
Yes, we started patching.
You started patching now.
Thank you.
Thank you. Is Dr. BP Kashyap here? Okay. He is going to stand for MLA this time. Wish him all the best. So anyway, since this topic was selected by out of a lot of, I think 86 entries, and we'll just play without any marks.
Track with a small eye, a 55 years male patient requiring plus 30 diopter IOL. I generally start rhexis with needle and complete it with Iterata forceps. In this case, I started rhexis with needle after puncturexis. Halfway through, I took out my needle. I put in more visco and entered AC with Iterata forceps. After a while, the free flap was eager to come out of the AC. I pushed the free capsular part of the rhexis towards the center. By this time, the AC totally collapsed and had no means to remove the Iterata or reform the AC by visco. If I move my forceps, the rhexis margin had to go the Argentinian flag way. I had no side port made for me. What next? I yelled, "Visco do, jaldi do." Assistant replied, "Kahan sir?" Suddenly something struck me. "Beech mein ghusao." "Kahan sir?" "Are main incision mein ghusao jaldi." And she did it. She pushed the visco through the gap of the two blades of the forceps. Free margin went inside. I took out my forceps. Made a side port, injected more visco, completed the rhexis, and rest was usual and uneventful. The lesson learned is, my friends, must make a side port also along with the main incision, and must train your assistant to come in for a rescue the time when you wanted them.
Dr. BP Kashyap was the winner of 2022 for 2 minutes to win, and he's not here today. And here we move to the next talk, that's by Dr. Hridaya Mohan, peel, lift and after sculpt.
Peel, lift and after sculpt technique. This is a novel technique for breaking the leathery, tenacious posterior plate in Brunnesen cataracts, and it is especially useful in the setting of weak zonules. First, circumferential peripheral chops are performed and endonucleus is separated. The epinuclear petals are then peeled towards the center using the phaco probe rather than laterally separating them, thereby minimizing zonular stress. And while peeling the petals, using the second instrument, the neighboring epinuclear piece is pushed posteriorly in order to give traction so that the leathery posterior plate can be peeled while pulling to the center and the petals get released. This action is difficult to be performed 360 degree. So once a clear area is created after peeling, the clear area is rotated and brought subincisionally, visco is injected, and using a blunt-tipped cyclodialysis spatula, the leathery posterior plate is lifted up. The intact capsular rhexis keeps the posterior plate in this elevated position. Visco is injected and posterior capsule is pushed down, and using our phaco probe, the leathery posterior plate is sculpted. Once the tenacious fibers are removed, the remaining epinuclear Brunnesen bits can be emulsified very easily. This technique doesn't require a lot of lateral separation, which causes zonular stress. Rather, there is peeling and sculpting. This brings down the phaco time considerably and ensures clear cornea post-operatively.
Yeah, good technique altogether. But there are different techniques has been described by many of the people. Suppose like I do 5-6 techniques for very hard cataract.
Yes.
I normally do 6 chops without eating, and then first I eat the center part, the egg
Yes.
part I eat, then again I do. That again will not putting you more stress over the zonule.
Yes.
So whatever the type of technique you choose, you have to be best in that. Make sure that you are not putting any stress to the zonules.
Yes,
The
sir.
amount of the energy you are going to give is as less as possible.
Yes.
Thank you.
Sir, I would just like to put in a word. I think this technique is more useful in my hands with when I'm not having a very good machine like Centurion or something. Legion probe tends to get occluded very frequently, so this technique is actually very useful when
And
you're
also,
using.
what kind of chopper also use also very important.
Yes, sir.
So always harder cataract, best to do vertical chop than horizontal.
Yes, sir.
Okay, thank you.
Thank you, sir.
Thank you. And now we move on to the next up by Dr. Nandu Prakash. It's a chicken suturing in a Brown syndrome patient. Dr. Nandu Prakash.
This patient, there was an elevation defect in the adductor position, and there was positive force reduction test. Conjunctival peritomy was done, and superior rectus was hooked and exposed. After that, superior oblique muscle was identified and hooked. And sutures were passed to fix both ends. And 4 mm was measured in superior oblique. After fixing both ends, 8 mm loop was made. The suture used was 50 Edbon non-absorbable suture. After that, superior oblique muscle was clipped and it was cut. After force reduction test, postoperatively, here we can see in the adductor position there was a slight improvement in elevation.
Okay, thank you.
It was good. Your 2 minutes made look like 20 minutes.
Yeah.
You're so relaxed about the whole thing. But is this like why the chicken suture? Why the name chicken?
The superior oblique muscle was cut from both ends and to elongate the muscle.
No, I'm just, don't get stressed. I'm just asking where the name chicken came from. The chicken suture.
It's an interesting one, I think.
Just
But
interesting, like which thought came up, why not goose or geese or bird or duck?
why chicken?
Why chicken?
Is your preference or?
Is this a described procedure, the suturing, or is it a novel technique?
Did it explain any of the textbook that chicken suture is put for the?
No, in this patient, this one was preferred.
No, what made you to give that name called chicken suture? That's what Madam
Describe.
described. That's what we wanted to ask. Right.
That's good.
Thank you.
Thank you very much.
Sir.
So we move on to the next talk by Dr. Rashmi Kumari. She is going to speak on Faco Blues, Mystery Demystified.
Trypan blue staining of the posterior capsule or vitreous is commonly reported with cases of zonular compromise either due to trauma, surgery or pseudoexfoliation. Trypan blue does not have a toxic effect on retinal pigment epithelium cells as reported in animal and human study. But blue fundal glow can obscure the red fundal glow during phacoemulsification that can lead to intraoperative complications. In this video we will demonstrate how to prevent percolation of trypan blue dye into vitreous in case of large area of zonular dehiscent. This is a case of traumatic cataract having 5 to 6 clock hour subluxation, planned for phacoemulsification with implantation of capsular tension ring and capsular tension segment. A viscoelastic barrier is being created by injecting 1.8% sodium hyaluronate in the area of subluxation to prevent posterior percolation of trypan blue dye. Anterior capsular staining is done under air technique. Capsulorhexis is being performed and capsular bag is anchored with capsular hooks. Stability of bag is ensured with implantation of capsular tension ring. No obscuration of red fundal glow due to posterior percolation of blue dye is noted while performing phacoemulsification despite having large zonular dehiscence. To conclude, creating a viscoelastic barrier over the area of zonular dehiscence before staining of anterior capsule can effectively prevent posterior slipping of dye. Thank you.
How did the case end? Like what lens did you choose and how was the black bag stabilized once you removed the capsular hook?
And that was for CTR was used and along with capsular segment.
Yeah. So the segment, you used the segment to stabilize the bag and do a routine.
Yes, ma'am.
Would have been nice to just show that one last clip also that this is the last thing.
Thank you so much.
Thank you. Thank you very much. The next talk is by Dr. Shama Devedi. She is going to speak on ET calculation, a simple procedure with gratifying results. Dr. Shama. Would you like to speak also?
Yes, sir.
I'll just restart.
Thank you, sir. ADT chelation is a simple procedure. Band keratopathy is seen in association with many diseases, but due to inaccessibility to EDTA, usually these patients suffer. Now we present a 6-year-old female who has bilateral band keratopathy and the preparation of EDTA solution which is emphasized in this video. For this we require 1 ml sterile water is used in the vacutainers. These vacutainers are routinely available in all the pathology labs and we rub them with a sterile bud, and this 1 ml solution of EDTA is passed successively in the 4 vacutainers and the procedure is repeated to collect the nearly it is around 21 milligram of EDTA if you calculate the whole amount, but considering some amount is lost during the passage, we presume the concentration to be 2%. So we perform epithelial debridement and take a very small cotton bud and soak it with EDTA and keep it over the cornea for 1 to 2 minutes. Thereafter we irrigate and remove this with a cotton bud applicator or even with a 15 number scalpel blade. But in our patient, when we tried to do this, still lot of calcific deposits were remaining. So we repeated whole of the procedure. Usually the literature says to apply EDTA once. We applied it twice, and then whole of these deposits could be removed, and in the end the cornea was clear after rubbing, and in the end BCL was applied. So this video emphasizes that with the availability of EDTA vacutainers which are available in your pathology lab, you could get such clear corneas, and the vision in this patient was achieved 6/6, although she had anterior uveitis. But since the cornea became clear, this 6-year-old child could have useful vision from her right eye, although the left eye was thicical and had band keratopathy, but we did not used the procedure for the left eye.
I think very good technique.
Very
we
good
keep
technique.
looking at fancy things, PTKs, femtos, and forget the basic
Actually,
EDTA.
the
Pretty good.
PTK is not so good in this because
have
there is presence of calcium, so that these lasers don't work so uniformly.
Yeah.
So actually, the PTK is less good than this chelation method.
And does the patient have to be on some kind of drops like anti-chelating
We
for a
give
long term?
antibiotics till the epithelium heals along with BCL, and once the epithelium heals, then we give mild steroid, because definitely the inflammation is there due to the use of chemical.
But no chelating drops
No,
required
no,
in
no,
some
no.
kind of form.
That
for a
is only
recurrence
the
or something.
intraoperative procedure.
Can we have some side effects by overuse of it or overexposure?
I don't
You
have
use it
that
twice,
much of
yeah.
experience. There was mild inflammation only. No, there was no such side effect in my patient, but this is a single case.
That's a good one.
Thank you, sir.
So now we move on to the last but not the least talk by Dr. Lalit Verma. I would like to tell you that when I conceptualized this idea of 2 minutes, it's a Dr. Lalit Verma who pushed me, who supported me, and say, why don't you bring it to where you
No, the reason
Thank
was
you so much.
There can be a lot of learning in 2 minutes. So, Nani, this is, audio is
We
already
discuss
there.
about doctors and patients' cooperation, which is the essence of every other ophthalmic surgery. In our practice, most of the surgeries are carried under local anesthesia, but sometimes a top-up of sedation is required in hyperactive patients. Here is a similar case of an anxious old man who presented to us with a macular hole and lots of expectations. We began the surgery under periburbar block, and as the patient got a little restless, a bit of midazolam was added to give some sedation. The patient slept but suddenly woke up with a jerk. As a result, the cutter hit the retina, causing profuse bleed. We took a pause, calmed our nerves, and continued with the surgery. Blood clot provided the needed hemostat. Fortunately, bleeding did not compromise the field, and we continued with staining. Careful peeling of ileum was done surrounding the macular hole. During surgery, we noted that the blood was underneath the ileum, which was carefully removed by extrusion cannula. As trauma could lead to the formation of possible retinal breaks, we lasered at the site of injury. Surgery was concluded after fluid air exchange and gas injection, and thereafter we prayed for patient's recovery. We followed the patient over a month. At first week, there was some dispersed bleed inside the vitreous cavity, and at 1 month, the vision improved to 624, the foveal contour regaining, and traumatic side healing. So to conclude, talk to patient prior to any surgery, ensuring full cooperation. Use sedation only to allay anxiety and not to make the patient sleep. And in time of crisis, don't be in haste. Take a pause, think, and then go. Thank you for your kind attention.
Excellent, sir, excellent. The man who is teachers of teachers still want to teach us something ultimate, sir. You are still in the field of teaching, still making us work very hard, sir.
Teaching is
You are
lifelong.
always awesome as usual, sir.
No, lifelong. The only purpose, if I can make a small comment, is that over sedation is very harmful. You
Yeah.
see, this patient was doing well, but because he was moving, we anesthetist gave more shot of midazolam, and he slept. Suddenly he woke up, and the light pipe touched the retina. So therefore, over sedation should not be done. Thank you.
Thank you so much, sir. And before we come to the end of this session, I think the judges will club their results. And meanwhile, I request Dr. Lalit Verma sir to come here, just to give this an award to Dr. B.P. Kashyap. Couldn't make it's an award for the last year. Dr. Bharti can receive it.
All the best for BP Kashyap, who is standing for MLA election. That is the main thing. Definitely is going to win also.
The winner of this time will be awarded in the annual conference. Thank you so much, everyone.